Good morning, everybody. For my talk, it's going to be a little different. If you have your registration kits, my handout's in there. If you want to take it out, we're going to follow along on the handouts, not on the slides. So I want to thank everybody for coming. Vision involves a lot of different aspects. A lot of times when you go to the eye doctor, they're checking your vision, you get your glasses, and if the glasses work, you're good to go. But unfortunately with MS, there's a lot of problems that can affect your vision that won't get improved or can't get fixed with regular glasses. And so what I'm going to focus on mostly is optic neuritis and problems involving the optic nerve. I'll also talk about some other problems that can affect vision as far as like double vision and something where your eyes jump called nystagmus. But before I talk about that, I'll talk about the optic nerve and optic neuritis. When we talk about MS, we focus on the central nervous system because that's the part of the body that gets attacked by the immune system that causes all this damage. And when we talk about vision, the optic nerve is actually a direct extension of the brain to the eye and is part of the central nervous system. And so in many patients who have MS, they will have an attack called optic neuritis where the immune system is actually attacking the optic nerve. Vision complaints are very common in MS overall. About a third of patients will complain that they have some type of visual problems, blurry vision. Double vision is another common problem that they can have. And many patients will complain that some of their disability is purely due to their vision, or one of the components of their disability is due to their vision. Optic neuritis itself is where the immune system, as we talked about earlier in the earlier talks, the T cells, the B cells, they're actually attacking the optic nerve and causing inflammation. And the myelin surrounding the optic nerve gets damaged, and that can cause acute painful vision loss. Usually what happens is that patients might notice the pain initially. That will be the first symptom. It'll be pain on eye movements. So not every time you have eye pain, you're not having optic neuritis. Lots of things can cause eye pain. You can have dry eyes. You can have migraine headaches that can cause eye pain. But in this particular type of pain, it's actually worse when the patient moves the eye around. And then they'll notice gradually that they're getting this blur in their vision. And it might feel like there's a haze or like there's some kind of cloth blocking their field of vision in that eye. And typically, optic neuritis affects one eye at a time. So when somebody's having an attack of optic neuritis, usually not, sometimes both eyes can be affected, but the majority of times, especially with MS, it's one eye that's affected. Why that is, it's not entirely clear. You think if the immune system's attacking the central nervous system, you have two optic nerves, why one is selected and the other isn't, it's not entirely clear, but that's the way it happens. And the vision loss that occurs will happen over a period of hours to days, and usually the vision loss gets to its worst point within a couple of days, and then it will spontaneously get better. And it's kind of peculiar, but this is a form of vision loss that tends to get better on its own, but steroids will obviously, if patients here have had optic neuritis know, if you get IV steroids, it will accelerate the recovery and your vision will get better much more quickly if you get the steroids. And so if you get diagnosed with optic neuritis, your doctor will typically prescribe several days, maybe 3 days of IV steroids, and then your vision will recover. But it usually never gets completely back to normal. If you start off with normal vision in that eye, say 20/20, it might get better to 20/20 again, but there'll be other factors that are affected. If you flip to the second page, I kind of talk about how vision loss is affected in optic neuritis. And so if you look at the bottom left, vision loss, we talk about visual acuities. 20/20 is considered normal, and that's, again, what your doctor will check when you go to the eye doctor when they're screening your vision. But when you go to see a neuro-ophthalmologist or an MS specialist, we might focus on other aspects of your vision that are affected in optic neuritis that are affecting your vision. So color vision is a very significant component of your vision. The ability to see colors and discriminate different colors can be lost even more out of proportion than your visual acuity when you have optic neuritis or MS. In addition, low contrast acuity can be affected. I'll talk about that a little bit later, but low contrast acuity is your ability to discriminate different grayscales. And that also can affect the quality of your vision, and it can affect your ability to have depth perception issues. And then your visual field is also very important. So when you're talking about visual acuity, that's your ability to read the really small print at the bottom of the eye chart. So if you look at the eye chart here, there's the big E on the top. And then as you go down, if you can read the bottom line, that's usually the 20/20 line. If you can read that, that's great, but that's not the only aspect of vision that's important, because your visual fields are very important. Your visual fields are the areas of your vision that you can see centrally and then peripherally. And if you can see 20/20 vision, but you can only see it in a small island of vision and everything else you can't see, you're essentially going to be visually disabled or visually blind because you're not going to see people next to you. You're going to be walking into walls. You might not be able to see food on the plate in front of you. You might not be able to drive. And so that can be quite disabling. if you go to the third page, I have on the top there the eye charts. And on the left is a regular eye chart with the black and white letters that we typically see when we get our eyes and vision checked. But if you look at the colors of the letters to the next to that, they're kind of gray and diminished. And we know that when we test patients' vision in MS, they can do great on the chart where it's black and white letters. But when you get to the gray scale, all of a sudden they do much worse than people who don't have MS or optic neuritis. And so we call this low contrast visual acuity, or these different gray scales of vision. So these shades of gray, if you will, 50 shades of gray, right? So the very low contrast visual acuity is predominantly affected in MS patients, and they really have a hard time with this. And we know through studies that have been done in MS patients and patients with optic neuritis that their loss of low contrast visual acuity actually correlates with their MRI scans and the atrophy we see on their MRIs and on their disability. So we know this is a very important component of vision. So if patients come in, they have complaints of vision loss in MS, and their visual acuity is 20/20, one of the things I'll consider testing is looking at their low contrast visual acuity, because that might be more impaired than their regular visual acuity. If you look at the color vision plates are also very important for testing. And I know a lot of the MS doctors who aren't even eye specialists will test this in the clinic because they realize that color vision is an important component of vision. And patients who've had optic neuritis, or even MS patients who've never had optic neuritis, once they recover, their color vision might not fully recover. Even if you get back to 20/20 vision, the eye that had the optic neuritis may never really fully get back to normal color vision again. And you might not think about it on a day-to-day basis when you're looking at things, but when you lose your ability to discriminate colors, that can really affect your ability to do your job, depending, you might have trouble driving if you can't see the traffic light colors as well, or you might have trouble doing other types of jobs or activities with the loss of color vision. And so that's another thing that we can help figure out. Is the vision loss due to optic neuritis or MS, or is it another problem like a cataract where we wouldn't expect the color vision to be affected? And then visual field testing. So I have a picture of visual fields here. Visual fields can actually be tested on a machine. So they have machines, if you go to the eye clinic, we can actually use a computer to map out where your vision is normal or where it's abnormal, where it's missing. It's kind of a boring test. You kind of, if you're not awake, if you're not feeling well that day, you might have a lousy test result. So when you're doing a visual field test, you want to make sure you're awake, alert, you're feeling relatively healthy, and concentrate on it. And when that test is done, it takes about maybe 10, 15 minutes. You can map out where your visual fields are, and you can see if you've had optic neuritis or MS-related vision loss, where and how bad your vision loss is, and you can track it over time. And the great thing about this test is that the computer can compare your prior visual field test to your next visual field test and say, okay, you had IV steroids, or your doctor put you on a medication for your MS. Is your visual field actually getting better, or is it getting worse? And we can map that over time. The visual field tests, again, are subjective. So if you're not feeling that well that day that you did it and it looks really bad, you can have your doctor repeat it maybe on another day when you're feeling better and well rested, and maybe just because you weren't feeling well, it'll get better. The next test I'm going to talk about is OCT. I'm not sure if anybody's heard of this before. It's a relatively new technology that we use in multiple sclerosis. It's optical coherence tomography. And it's really revolutionized the way we look at MS and the optic nerve and vision in MS. What it uses is near-infrared light. So you go to the eye clinic, and it's a machine. You put your chin there. It takes, again, about 10, 15 minutes. Typically, we do not need to dilate your eyes for this test. And what it does is this near-infrared light gets beamed to the back of the eye, and then some of that signal bounces back. The computer analyzes that signal, and it can measure the thickness of the back of the eye. If you go to the first page at the bottom, I have a picture of the back of the eye. So people always ask me when I'm doing an eye exam, Doc, what are you looking at in the back of the eye there? I tell them I'm looking at the optic nerve, I'm looking at the retina, but this is actually showing you what I'm seeing. So I'm looking at the optic nerve, I'm looking at the retina. Sometimes I can see abnormalities there if they're having vision loss, but sometimes it actually looks normal. If somebody comes in with sudden vision loss from optic neuritis, the optic nerve actually might look quite healthy and look normal when I look in the back of the eye. But the OCT is very helpful because this machine has very high resolution. It can measure down to the micron level. So the normal retina is about 100 microns thick. It can measure down to like around resolution of 5 to 6 microns, measuring different sub-levels of the retina. And we can find certain patterns of retinal damage in patients with MS that can help us see how they're responding to treatment, how bad the vision loss is. And it might even help us figure out, was this MS-related vision loss or something else causing your vision loss? And again, this optical coherence tomography is like the visual fields, we can track from test to test. So if you have optical coherence tomography scan now, and then you get it repeated 6 months later, a year later, we can track it, and the computer can tell us if there is loss of the retinal thickness, and that can correlate again with your MRI. And now they've done studies that the results of the OCT scans can actually correlate with MS disability and even potentially predict disability in patients with MS. Going back to page 3, so when we look at patients with optic neuritis who get the OCT scans, we know now, based on studies, how much retinal loss we can expect patients to develop. And we can predict that they'll lose maybe 10 to 30 or maybe even 40 microns of their retina after an attack of optic neuritis. About 3 to 6 months, we'll be able to measure that after an attack of optic neuritis. And then we can track that over time and see if their retinal neurofibrillator is getting worse or not. So I'm going to go through a case now of optic neuritis. So if you go to the page 4, there's a case there. It's a 38-year-old female. She comes in, she's noticing blurry vision, she has some pain and eye movement, and it's been going on for the past 3 to 4 days. And she has this history of carpal tunnel. She thought she had carpal tunnel because she had some tingling in her left hand, but she's never ever seen a neurologist before. And when I see her in clinic, her visual acuity in the right eye is 20/80, which is not normal. Her left eye is normal 20/20. When she gets her visual field test, you can see there are these areas where the black dots are. Those are the areas where her visual field is knocked out. So if you look at that map, that should not really have almost no black dots there. So about 3/4 of her visual field have been knocked out by this optic neuritis. And on her color vision testing, she can only see one of the color plates correctly in the right eye. In her left eye, she can see all the color plates. When I look in the back of her eye, that's again a picture of the optic nerve. It looks pretty unremarkable. Most of the time when patients have optic neuritis, their optic nerve looks pretty healthy. One thing that's really interesting to me when I'm seeing patients with optic neuritis is that when I'm looking at that optic nerve, that's the very front of the nerve, that's actually the most anterior aspect of your brain that we're actually looking at when we look at your optic nerve. So it's really the only way, without doing neurosurgery, which I don't do, of actually getting a direct look at the brain and seeing what's going on. It's a direct connection between the eye and the brain. And so we send this patient for an MRI, and lo and behold, that MRI shows that there is inflammation in the optic nerve. That inflammation tends to take place in the part of the optic nerve we can't see. That's why it looks normal when we look in the back of the eye. But most of the optic nerve is actually behind the eye, tracking towards the brain. And that's the area where we see the abnormalities on the MRI. And then when they do the rest of the MRI, if you look to the last page, there's these white matter spots that suggest that this patient has MS. About 50% of the time when somebody has optic neuritis, they might not always have MS. So sometimes people have optic neuritis and it might be they have nothing else going on. We'll never figure out the cause. They might have another disease like neuromyelitis optica or a sarcoid. But about 50% of the time when patients have optic neuritis, it's due to multiple sclerosis. And so it could very well be when the patient goes to their eye doctor, it'd be their eye doctor who actually makes the diagnosis or helps initiate the diagnosis of multiple sclerosis. I'm going to shift gears now and talk a little bit about other symptoms that can occur with vision in MS. So one of the other common complaints I get from patients when they have multiple sclerosis is that they have double vision. And double vision is due to the fact that your brain not only processes the vision of what we see, but it controls how your eyes move. Remember, each eye is a separate camera, basically, and if you want to see a single image, they have to be working in synchrony. And your brain is controlling those movements. So just like if you have MS and your right arm is affected and your right arm isn't moving well because of your MS, well, if your right eye isn't moving well, if your left eye looks over here and the right eye just stays there, all of a sudden this eye's looking that way, this eye's looking that way, you're not going to see a single image anymore. Now you're going to have double vision. And that's not uncommon in MS because there's a part of the brain that controls your eye movements in the brainstem that connects and controls and basically yokes the two eyes. We don't really think about it. We move our eyes around all the time, and they flawlessly move. We don't even consciously command our eyes. They just subconsciously are moving wherever we want them to a lot of the time. And they'll reflexively move together like synchronous swimmers or synchronous dancers. But when one of those guys lags behind the other eye, then all of a sudden you can have blurry vision or double vision. And sometimes the eyes will get completely paralyzed. So there's this picture here. You can see one eye's looking straight ahead and the other eye's looking off askew. And so what we can do in the eye clinic is, first of all, we can try and assess, is the double vision due to the MS? Sometimes people have double vision that has not due to the MS, but it might be due to the fact that they have really bad dry eye or they have a cataract. But once we figured it out that it's due to the MS, there's a couple treatment options. One could be just patching that eye temporarily because maybe it's just an MS relapse and we treat it with steroids and then the double vision will go away when you get treated with steroids. Or another option might be putting something called a prism over your glasses. And the prism might help realign the eye so it gets rid of the double vision. And so that's something we can measure for in the eye clinic to help fix that. One of the common causes of double vision MS is something called an internuclear ophthalmoplegia or an INO. I don't expect you to memorize that, but I wrote it there. Sometimes I tell patients when they're in the clinic, they want to know why they're seeing double, so I explain to them they have this condition called an internuclear ophthalmoplegia, or INO. And it's basically, again, because those two eyes aren't yoked together. They're not moving smoothly together. Another problem that you can get, however, is that you can get a tremor in the eyes. So when the eyes are not moving voluntarily, but one of them starts to bounce up and down or sideways, we call that nystagmus. So nystagmus is where the eyes are involuntarily jumping around or jerking back and forth. And they might both do it, or it might just be in one eye, or they might both be doing it, but one eye is doing it, and it's more obvious in one eye versus the other. And this is probably one of the most disabling symptoms and most difficult to treat symptoms in multiple sclerosis. We can try a lot of the medications that were listed earlier for spasticity to try to suppress the nystagmus, or sometimes we'll use anti-seizure medications. These are not seizures, but we use anti-seizure medications off-label because sometimes they can also help treat nystagmus, and those slow down the speed or amplitude of those eye movements to help get rid of the nystagmus. In very rare cases, patients might actually benefit from eye surgery to suppress the nystagmus, but that's pretty rare. Most of the time we try to manage it with medications. The problem is all those medications, once you get enough medication on to dampen the nystagmus, all of a sudden you're dizzy or you're fatigued or you're having other side effects from the same medications to treat the nystagmus. So it can become quite the balancing act trying to treat nystagmus with the medications because a lot of times the patients are already on other medications and they won't be able to tolerate those medications due to side effects. But I think I'm going to end my talk there, and I'll answer any questions at the end during the Q&A session.